Welcome to the Deep Dive. Today we're digging into something pretty challenging, looking at sources that kind of push back on how we usually think about recovery, especially for a really marginalized group in society.
Yeah, we're talking about individuals dealing with what's often called co-occurring disorders.
Right, so people managing both a serious mental illness, like schizophrenia,
Yeah.
bipolar disorder, and at the same time, a substance use disorder, addiction.
It's pretty much the definition of a high-risk group. I mean, just managing one of those is incredibly hard, let alone both.
And the outcomes show it, don't they?
Absolutely. These folks often struggle intensely. You see high rates of poverty, unemployment, chronic homelessness, and they often get tangled up in the criminal justice system again and again.
And for decades, the reasons given have been pretty consistent, right?
Yeah, clinicians, researchers, when they looked at why these individuals struggle so much, it usually got pinned on just two things. Either how severe the mental illness was, or how bad the substance abuse was, or maybe socioeconomic barriers.
But the sources we have today, they bring in this third factor, something that's been, kind of hidden in plain sight, maybe.
That's exactly it. We're bringing traumatic brain injury, TBI, into this whole picture. Historically, studies looked at TBI or they looked at dual disorders. Very rarely did they look at where those two things intersect.
Until this research we're looking at.
Right. The work by McHugo and colleagues, it reveals this genuinely stunningly high rate of TBI in this exact group. And the implication is huge. Meaning that failing to even ask about past head injuries likely leads straight to misdiagnosis and, critically, to treatments that just don't work.
So our mission today is to unpack the data points that really show why ignoring TBI history can set people up for this cycle of failure.
Yeah.
How an old injury can mess up recovery right now.
Yeah, how it actively prevents recovery.
Okay, let's unpack this. So let's start with the context, just setting the stage. The sources definitely confirm this high-risk environment these folks were in. Homelessness, trouble with the law, we know that. But the argument is that these problems are often just blamed on the psychiatric symptoms, or the need to get drugs.
Exactly. That's the historical blind spot. Assuming the poor functioning is just a symptom of the mental health or addiction issues, this study wanted to see if earlier, smaller findings held up in a bigger urban group.
To see if TBI was a real measurable driver of these bad outcomes.
Precisely. Was it contributing significantly?
But they recruited, about 300 people?
Yeah, 295 participants. They came from an outpatient community mental health center in Washington, D.C., all seeking integrated treatment.
And they all had confirmed diagnoses, both serious mental illness and a substance use disorder.
Correct. DSM-IV Axis-I diagnosis for the mental illness and an alcohol or drug use disorder. So a very specific, very challenged group.
Okay, so how do you even assess for TBI history accurately in a population like this? Memories can be fuzzy, trauma involved.
That's a great question. You need something systematic, reliable. They use the Ohio State University TBI identification method, the OSU TBI ID. It's designed to retrospectively document a lifetime history of head injuries, but it focuses specifically on injuries that either did require medical attention or logically should have.
So it tries to get past just a minor bump on the head memory.
Yeah.
It adds some objective criteria.
Exactly. It standardizes it, gives a more objective read on actual neurological trauma history, not just subjective recall.
All right, let's get to the core finding then, the prevalence. In this group of 295 people already facing these huge challenges, how common was TBI?
Okay, brace yourself. It's genuinely startling. Out of those 295 people, 80.3% screened positive for a history of at least one TBI.
80%.
Yeah.
Just, wow, 4 out of 5 people.
4 out of 5.
I mean, you compare that to other high-risk groups, like, say, people who are incarcerated, meta-analyses put that closer to 60%, maybe? This is significantly higher.
It's substantially higher. It's hard to even think of another medical condition that's that prevalent in a specific psychiatric group. The sheer scale of it is, it's hard to overstate.
And it wasn't just, mild concussions they were talking about.
No, not at all. And that's the next critical layer, the severity. A full quarter of the sample, 25.4%, reported at least one TBI that involved a loss of consciousness, LOC, lasting for more than 30 minutes.
Okay, and that duration, the 30-plus minutes, that puts it into the moderate or severe TBI category, doesn't it?
Yes, absolutely. That's a significant injury. We're not talking about getting your bell rung for a few seconds.
And were these single events, or was there a pattern?
That's another crucial point. It wasn't just one bad hit for many. Among those who did report a TBI with LOC, the average number of times that happened was almost 1.82 to be
Like
exact.
average, meaning some had many more.
Oh, yeah. The range went up to 21 reported instances of TBI with loss of consciousness for some individuals.
Imagine the cumulative damage.
Staggering. When you see that level of repeated trauma, you have to ask when it started. Does the research give us a sense of the timeline? It does, and this is where it gets really concerning for long-term implications. 36%, over a third of the participants who had experienced LOC. They had their first TBI with LOC before they were 15 years old.
Before 15, during critical brain development years.
Exactly, while the brain is still wiring itself up.
How does that stack up against the general population? Is that typical?
Not even close. It's a massive difference. In the general U.S. population, studies find less than 7% of adults report a TBI with LOC before age 15.
So this group's rate is, what, more than 5 times higher?
More than 5 times higher, yeah. It strongly suggests this neurological vulnerability starts really early for many in this group, maybe even before the mental illness or addiction fully takes hold, or certainly interacting with it from a young age.
And I remember reading there were some differences depending on their psychiatric diagnosis, too.
Yes, that's right. Men and participants who had psychotic disorders like schizophrenia tended to have a significantly earlier age of first TBI with LOC compared to women or those with mood disorders like depression.
Which kind of reinforces that idea of early trauma potentially being linked to the type or severity of the later psychiatric illness.
It definitely points in that direction. It suggests this early brain injury might be really intertwined with how these severe psychiatric conditions develop and manifest.
Okay, so TBI is incredibly common, often severe, often repeated, and starts early for many. The next logical question is, how does the severity of all that injury link up with the really difficult life outcomes we talked about earlier?
Right. How does it connect to things like homelessness, arrests, ongoing substance use?
And to measure that severity, they didn't just count injuries, did they? They used something called the TBI weighted sum.
Correct. The weighted sum is a more sophisticated measure. It doesn't just count how many times someone hit their head. It combines the total number of injuries, but gives more weight to the ones with more severe markers.
Like longer loss of consciousness.
Exactly. Longer LOC or having post-concussive symptoms that needed medical help. So it gives you a better overall score for the lifetime neurological burden someone's carrying.
Makes sense. A much stronger measure than just asking, ever hit your head?
Much stronger. And that weighted sum score turned out to be a powerful predictor of bad outcomes.
Okay, let's break those down. What about substance use?
Well, here's something interesting. The TBI weighted sum was significantly correlated with current days of alcohol use, and specifically with days of heavy drinking defined as 5 or more drinks in a day.
Specifically alcohol. That's quite specific. What about other drugs? Illicit drug use?
Surprisingly, no. The study found TBI severity was not linked to the number of days they'd used illicit drugs in the past 3 months.
Huh. Any thoughts on why?
It's hard to say for sure from this data, but it might suggest TBI specifically worsens behaviors tied to alcohol. Maybe it impairs executive function or impulse control in a way that makes stopping drinking harder once you start. Or perhaps the environments where heavy drinking happens are also higher risk for TBI. It's a specific link that needs more exploring.
But it definitely changes how you might think about alcohol addiction in this group. It's not just craving. It could be like physically damaged inhibition circuits.
Absolutely. Physical brain damage potentially driving the behavior.
Yeah.
And the links go further. When you look at those broader, really adverse life outcomes.
Homelessness, jail time.
Yeah. The weighted sum was strongly linked to more time spent in institutions, more negative interactions with the law. Specifically, it correlated positively with more lifetime detox episodes, more arrests for both nonviolent and violent crimes, a higher total number of times incarcerated, and more months spent literally homeless on the street.
Wow. So the TBI severity score tracked pretty closely with this whole cycle of instability and hardship.
Deeply entangled. It really suggests TBI isn't just another problem alongside the others. It might be actively predisposing people towards this chronic instability and getting caught up in the justice system.
And were there specific psychiatric diagnoses that showed a stronger link to higher TBI severity?
There were. TBI severity, both the weighted sum and just the score for their single worst injury, was significantly higher in people diagnosed with PTSD, post-traumatic stress disorder, borderline personality disorder, and antisocial personality disorder.
Okay, let's think about those diagnoses. PTSD, borderline, antisocial. They often involve things like trouble managing emotions, impulsivity, unstable relationships.
Exactly. And what are those? They're classic signs of potential frontal lobe damage or dysfunction. The very areas often hit hard by TBIs.
So the TBI might not just be co-occurring, it might actually be driving the severity or the expression of those specific personality and trauma disorders.
It seems very likely. It's not just an extra burden, it's potentially shaping the nature of their psychiatric presentation.
Which brings us right to the core issue, the biggest takeaway here.
Yeah.
The clinical implications. If 80% have a TBI history, and it's this destructive, why is it getting missed so often? And why does missing it lead to treatments that just fail?
Yeah, this is the crux of it. The main reason it gets missed is something called diagnostic mimicry.
Mimicry. Meaning the TBI symptoms look like something else.
Precisely. TBI, especially when it damages the frontal lobes which control our executive functions like planning, working memory, attention, impulse control, causes symptoms that look exactly like the symptoms of primary psychiatric illnesses.
So a clinician sees someone who can't plan their week, drifts off in therapy sessions, has emotional outbursts, and they think, okay, that's the schizophrenia, or that's classic borderline personality disorder.
Exactly. They naturally attribute it to the known psychiatric diagnosis. They treat that apparent symptom, often with medication, but they completely miss the underlying neurological damage from the TBI.
And that creates a fundamental treatment conflict,
A
right?
huge conflict. Think about it like software versus hardware. Psychiatric meds like antipsychotics are mostly designed to fix a software problem, maybe a chemical imbalance, neurotransmitter issues. But TBI causes a hardware problem, physical damage to the brain structure.
Right. So if the wiring is physically damaged, adjusting the chemical signals of the software isn't going to fix the broken wire.
That's a perfect analogy. The medication might just not work. Or even worse, the side effects of the meds could actually make the TBI-related cognitive problems worse, leading to the person functioning even more poorly.
And it doesn't just mess with medication effectiveness, it hinders therapy too.
Critically so. Psychosocial therapies, things like talk therapy, cognitive behavioral therapy, CBT, these are absolutely essential for recovery from both mental illness and addiction.
But why does TBI undermine them specifically?
Because these therapies require the patient to learn. They need to pay attention, remember strategies, practice new coping skills, manage impulses to use those skills. But TBI often directly damages attention, working memory, learning capacity, and inhibition.
So the very cognitive tools they need to do the therapy are compromised by the brain injury itself.
Exactly. The TBI is literally blocking them from being able to effectively use the tools that are supposed to help them get better. They can't benefit from therapy requiring high-level cognitive function if that function is impaired.
This really forces a complete shift in how we view this whole situation. The study authors argue it's not just additive. Like you've got mental illness plus addiction plus TBI, all separate.
Right. We have to see it as interactive. The TBI actually changes the person's mood, their personality, their ability to control impulses, their ability to learn, and those changes directly interfere with the ability to recover from the other two conditions using standard methods.
So identifying the TBI isn't just about adding another diagnosis to the list.
I know, it's about fundamentally changing the treatment approach, maybe prioritizing cognitive rehabilitation first, or using behavioral support specifically designed for people with acquired brain injury, before jumping to high-dose meds or complex psychotherapies that might be doomed to fail because of the underlying TBI.
And based on this pretty compelling data, they actually give some clear recommendations for who should definitely be screened, right?
Yes, they do. Given the strong correlations they found, TBI screening needs to become routine, especially for certain profiles.
Like who?
Well, anyone with a history of physical abuse, for sure. Anyone with military service history of playing contact sports, or a known severe alcohol use disorder. Those are big red flags based on risk factors.
And based on current presentation.
Absolutely. Critically, anyone presenting with a diagnosis of PTSD, borderline personality disorder, or antisocial personality disorder, and anyone with a significant history of homelessness and getting caught up in the criminal justice system, these individuals must be screened for TBI. We have to stop automatically assuming all these symptoms are purely psychiatric when there's such a strong possibility of an underlying neurological injury driving them.
Wow. So this deep dive really has uncovered a staggering truth. Traumatic brain injury is incredibly common. That 80% figure just sticks with you, and it seems to actively sabotage the traditional ways we try to treat dual disorders.
It seriously complicates the path to recovery, and yet it's still so often missed, undetected.
Which leaves people stuck.
If we connect this to the bigger picture, That finding about early childhood injury, the TBI happening before age 15 for so many in the sample, that's incredibly powerful, I think.
Because it messes with the cause and effect timeline we usually assume.
Exactly. The TBI often seems to come before the full-blown adult mental illness and addiction really manifest. The chronological order is suggestive, though proving cause and effect is always complex.
So it leaves us with a big question.
It really does. And it's something for you, the listener, to maybe mull over or explore more on your own. When we're faced with someone showing up with severe adult mental illness and addiction, especially with those risk factors we mentioned, should our primary focus maybe shift? Should we be looking to treat the developmental and neurological fallout of that potential early life brain injury first?
Using things like targeted rehab, cognitive supports.
Yeah, using interventions designed for brain injury before we expect the standard addiction treatments or psychiatric therapies to really take hold and succeed. The sources we looked at today certainly argue that without making that fundamental shift, we might just keep cycling people through systems that aren't equipped to address the root hardware problem and are therefore fundamentally failing them.